I'm absolutely convinced that nitric oxide therapies will completely eradicate Alzheimer's. And we're developing drugs specifically, nitric oxide drugs specifically for Alzheimer's. Because Alzheimer's is number one, it's a metabolic disease. And many people refer to it as diabetes type 3 because you see insulin resistance in the brain. The brain likes sugar as a primary energy source. And so if you can't get glucose into the cell, those cells become dysfunctional. When cells become dysfunctional, you get protein misfolding, you get amyloid plaque, you get tau tangles. But even before that, before Alzheimer's, which is characterized by amyloid plaque and tau tangles, we call the preceding condition vascular dementia. So it's vascular dementia because there's a vascular component to it. And when you look at cerebral blood flow or perfusion of the brain through SPECT scans or functional MRIs, you see in every single patient there's decreased blood flow to the brain. There's focal ischemia. There are parts of the brain that are getting no blood flow. So again, if you're not perfusing parts of the brain, you're not delivering oxygen, you're not getting glucose into the cell, and the cells become dysfunctional, proteins misfold, and that's what we call Alzheimer's. So what does nitric oxide do? It dilates the blood vessels. It perfuses the brain. It improves oxygenation of the brain. It improves glucose uptake. It potentiates insulin signaling. It prevents protein misfolding. That's Alzheimer's.
Hello, Dr. Bryan. You are the foremost researcher on nitric oxide and the founder, chairman, and CEO of Bryan Therapeutics, and also the author of The Secret of Nitric Oxide, Bringing the Science to Life. So, welcome back to Modern Healthspan, and thank you so much for joining us today.
Just great to be with you again. Good to see you.
So, Dr. Bryan, you've been studying nitric oxide for quite some time now. In fact, many decades, I think. So, what are
Okay.
some of the so how long have you been studying nitric oxide, and what are some of the biggest changes that you've seen in our understanding during that time?
Yeah. Now, look, I've been in this field now for more than 25 years, and this field has completely changed since when I first started until today. For example, in the late 90s, early 2000s, right after the Nobel Prize was awarded, there were about 40, 50,000 papers published in the scientific literature during that time. Actually, less than that. And today, there's over 200,000 scientific publications on nitric oxide. So in the late 90s, it was recognized that number one, nitric oxide is extremely important. It was discovered to be a signaling molecule in the cardiovascular system. But there wasn't any way to restore the production of nitric oxide, product technology that could deliver nitric oxide gas safely and effectively. And certainly no therapeutics besides inhalative nitric oxide therapy in the hospital setting. But today we certainly understand, number one, how the human body makes nitric oxide. We understand now what leads to a loss of production of nitric oxide. And today we certainly understand how to safely and effectively deliver nitric oxide gas that's therapeutic, that I truly believe is going to change the way we treat patients and will address root cause of disease and create a root cause medicine for every patient in the world.
So, nitric oxide is most famous for being for vasodilation, right, for blood pressure control. But I think it has, or you have found, like a number of other mechanisms that or functions that it performs within the body. So, what would you could you characterize what the main functions are?
Yeah, I mean, the first one to be discovered was as a vasodilator, right? So it dilates the blood vessels systemically and, leads to increased circulation, perfusion, normalization of blood pressure. But it's so much more than just a vasodilator. For example, it's how our immune cells kill off bacteria, viruses, any pathogens. So it's extremely important in our innate immune system. It's a neurotransmitter of the central nervous system. It's what leads to, long-term memory, potentiation, learning, memory recall. It mobilizes our own stem cells. So if you make adequate nitric oxide, you increase the number of stem cells in circulation. So you can repair and replace dysfunctional cells. You can regenerate things more better and recover from injury much quicker. It turns on the mitochondria, the energy producing organelles of the cell. So now your cells make energy more efficiently. And it prevents the shortening of telomeres, the ends of the chromosome that determine how long we live. So now there are many important signaling aspects of nitric oxide. They can turn genes on, turn genes off through epigenetic regulation of gene expression. So this very simple molecule is controlling really everything we know about health, longevity, and human optimization.
So nitric oxide is a gas, right?
That's right.
So so how do we make nitric oxide? I mean, we can't breathe it in. So yeah, what is the process by which the body generates nitric oxide?
Yeah, well, today we understand there's two primary pathways of production. Number one is there's an enzyme found in our endothelial cells, the cells that line all blood vessels. And this same enzyme is found in our neurons. In fact, most cell types will express this enzyme nitric oxide synthase. They just call it nNOS or eNOS because those are the cells in which they were first identified and cloned. But this enzyme converts arginine, L-arginine, which is an amino acid, into nitric oxide gas. And then once nitric oxide is produced, again, it's gone in less than a second. But during that time, it binds to these second messenger systems and activates these second messengers. And part of my work 25 years ago was trying to understand the metabolism of nitric oxide because we were interested, as you recall, nitric oxide's a gas and it's gone in less than a second. So what does it do? What does it become? And where does it go? And so I created that fingerprint of nanobiology back in 2001 and we published on this. So now we understand, even though it's physically present for less than a second, we understand how it's metabolized and kind of its endocrine or signaling functions. So that's number one. And then we find that the older we get, the less functional that enzyme becomes. So we produce less of that enzyme through less nitric oxide through that enzyme with age. But there's a completely independent and a compensatory or redundant pathway whereby nitric oxide can be produced through our diet, through the activity of oral microbiome and bacteria, and through adequate stomach acid production. So we know that a healthy diet, the Japanese diet, the Mediterranean diet, the dietary approaches to stop hypertension, is cardioprotective because we and others have published that those diets provide a molecule called inorganic nitrate. And then the bacteria that live on the crypts of the tongue metabolize that molecule into nitrite and nitric oxide. And then for this pathway to work, we have to have sufficient stomach acid production. So the secondary pathway is dependent upon diet. It's dependent upon adequate oral hygiene and the diversity of the microbiome, and it's dependent upon stomach acid production. And so today we know that a poor diet decreases nitric oxide production. Certain hygienic practices like fluoride toothpaste, like antiseptic mouthwash, kill the microbiome, leads to nitric oxide deficiency, and makes your blood pressure go up. And we also know that the third part of this pathway, use of proton pump inhibitors or antacids, completely shuts down nitric oxide production. And we're finding that people who have been on proton pump inhibitors have a higher incidence, in fact, up to 40% higher incidence of heart attack, stroke, and Alzheimer's. So we have a clear understanding of these production pathways and what's leading to a complete loss of nitric oxide production.
Okay, so the nitrates in the food, and so and the food would be like beetroots or leafy greens,
Leafy greens.
and these are the best source of nitrates. Okay, they get
They are,
converted.
people think, yeah, when people think of nitrate or nitrite, they think of hot dogs and bacon and cured meats. But really, the preponderance, the burden of nitrate, 85% of the nitrate we get from our diet comes from green leafy vegetables. Only 5% comes from cured meat products. So the burden comes from green leafy vegetables and a plant-based diet. So you're right. We need these green leafy vegetables.
And it gets converted from nitrate to nitrite by the
That's right,
by the
because
microbiome.
humans do not have the capability to do this. We don't have a nitrate reductase enzyme. It's only due through or accomplished through the bacteria.
So nitrites, at least within these cured meats, have been shown to be maybe related to cancer. I mean, do you have any thoughts on
Well,
that?
here's the misinterpretation of data. So number one, to answer your question, nitrite does not cause cancer. And this was played out through the National Toxicology Program in the early 2000s. In fact, nitrite at certain doses prevents certain cancers. And so here's how all this field started. In the 1950s, it was reported that nitrite cured meat, in this case, it was fish, that they found, and when they analyzed this, it contained what's called low molecular weight nitrosamines. So low molecular weight secondary amines can be nitrosated by inorganic nitrite to form nitrosamines. And then there are certain classes of nitrosamines that are known to be mutagenic and carcinogenic, right? And in this particular case, it was N-nitrosodimethylamine, and that's a known liver carcinogen. So then the nutritional epidemiologists were like, oh, nitrite cured meats can form nitrosamines, and nitrosamines cause cancer. So if A equals B and B equals C, then A equals C. And that was the jump they made, right? But it really never played out because if nitrite and nitrate caused cancer and form nitrosamines and cause cancer, then vegetarians would have, on average, 10 times higher incidence of cancers. Because again, 85% of the nitrate and nitrite you get from your diet comes from plant-based products. And in fact, we know that vegetarians have remarkably lower incidences of most, if not all, types of cancers. And really, the only cancers that we worried about were gastrointestinal cancers or stomach cancers with the nitrite. But and then what mechanistically when we look at number one, are there any low molecular weight nitrosamines in cured meat? And the answer is no. And so nitrosamines cause cancer, but nitrite does not cause nitrosamines. So therefore, nitrite does not cause cancer.
Okay. Does vitamin C help with nitric oxide bioavailability?
Absolutely. So vitamin C is extremely important in nitric oxide, not only nitric oxide production, working as an antioxidant to prevent the oxidation of tetrahydrobiopterin, which is the rate limiting step in nitric oxide production. But again, it prevents any nitrosative chemistry. So if there were any secondary low molecular weight amines present, and if you have vitamin C on board or ascorbic acid, it prevents that nitrosative chemistry. And then number three is it transduces nitric oxide bioactivity. So when nitric oxide is produced, it can bind to glutathione, transported as S-nitrosoglutathione, or be oxidized to nitrite in circulation. And then if we have sufficient vitamin C, it can release nitric oxide systemically from cysteine thiols and lead to this redox controlled nitric oxide release and delivery throughout the systemic circulation. So vitamin C is absolutely essential. And we as humans can't synthetically produce nitric oxide or endogenously produce nitric or vitamin C. And that's why it's extremely important that we get adequate supplementation of vitamin C or eat foods that are naturally enriched in vitamin C.
So going to the talking about the mouthwash. So I did look at some of the mouthwash studies, and they used what chlorhexidine mostly.
Chlorhexidine, right?
Yeah, which is it's a chemical. Right? So are all mouthwashes the same? Are they all? If you have like essential oil mouthwash, does it have the same effect?
Yeah, so you're right. Most of the clinical data, the clinical trials with mouthwash is using chlorhexidine. And that's for a reason because it's a very stringent antiseptic. It effectively kills all bacteria. In fact, it's used as a surgical scrub to kill the bacteria on the surface of the skin before surgery or before you make an incision. So we use chlorhexidine to completely eradicate the bacteria in the mouth, for example, in this study, because we wanted to look at the effects of if you completely eradicate the oral microbiome, which by the way, you never really can do. You maybe get 99% killing, but you never get 100% kill. And then look at the effects of that. But since those early data, investigators have used scope, Listerine, alcohol-based mouthwashes that you can buy over the counter. And you really get the same effect. You see the same phenomenon because, at least in the US, you see the commercials on TV, the adverts say, this mouthwash kills 99.9% of the oral bacteria. And, companies are advertising this. And obviously, they're not aware of the science because anything that eradicates the bacteria is not a good thing because we know that it's killing the good bacteria, it's leading to nitric oxide deficiency, and we see blood pressure go up in people who use mouthwash. So if it says antiseptic, believe it. And it's killing not only the bad bacteria, but it's killing the good bacteria. So we know all antiseptic mouthwash is bad. Now, when we talk about essential oils, oil pulling, and all these kind of maybe less stringent mouthwashes, We just don't have the data. Those studies have never been done. But I think as long as it's not antiseptic and it's indiscriminately killing all bacteria, the good, the bad, and the ugly, then it's probably okay. But if it says antiseptic, then I would avoid it.
Do you have any thoughts on xylitol? Just out of interest, because that also I think is antibacterial to some degree, but much less so than some of the others.
There's kind of a mixed bag of data on things like erythritol, xylitol, um, and there's some camps who believe it as a prebiotic because it kind of, um, some people think that it's restoring the healthy microbiome, and I think these are all dose-dependent effects. So I wouldn't personally, I wouldn't use like a xylitol rinse or an erythritol rinse as specifically for a probiotic. But I think in the case of what we do, when we develop products, we put those in there as sweeteners and as flavor enhancers, but at doses that doesn't seem to affect the microbiome because what we do when we deliver nitric oxide product technology, whether it's in the form of a lozenge, our new toothpaste, or we're in the process of developing a nitric oxide microbiome friendly rinse. We have these flavors in there, but what we look at is its effect on the microbiome, the non-pathogenic commensal bacteria that we're trying to repopulate and improve the numbers on. And in that case, it seems to have a positive effect at the doses we're using.
What dose is that? Do you,
Well, it's a very low dose, and so we're not
those?
looking at it specifically in isolation on its
Right.
effect on the microbiome. We're simply using this in combination with the other components we put in there as a flavor enhancer because when you make consumer products, it has to taste good, right? Nobody wants to put something in their mouth that doesn't have a pleasant
Yeah.
taste. And so we use these not as prebiotics, but to create a flavor profile in combination with everything else we put in there that makes it taste pleasant.
Okay. Yeah. So one last thing on oral. I saw that you liked tongue scraping as a thing. So I heard that Brian Johnson was doing that. So I did start, but I stopped. And then when I heard you liked it, so I started it again. So how does that help?
Well, this was an interesting observation, really an unexpected observation from a clinical study we published in 2019. And we were testing young healthy patients and looking at the effects of mouthwash on their blood pressure. And then we just gave them a simple survey to say, okay, what are you doing? What's part of your daily oral hygienic practice? And a lot of these people were flossing. Not a lot of people, but some people were actually doing tongue scraping either once a day or twice a day. And what we found when we looked at the data was that the people who did tongue scraping, daily tongue scraping, had a more diverse oral microbiome when we did tongue scrapings and cultured the bacteria. And remarkably, their blood pressure was much better than anybody else. So number one, our interpretation was simple tongue scraping improves the diversity of the oral microbiome, leads to more nitric oxide production, and their blood pressure seemed to be better. But the problem was when we intervened and started giving everybody mouthwash, the people who were doing tongue scraping that then used mouthwash had the highest increase in blood pressure. So our interpretation of that was tongue scraping alone is good. It seems to be beneficial. But if you tongue scrape, the last thing you need to do is use an antiseptic mouthwash because you get more effective killing of the bacteria and your blood pressure goes way up and sometimes 26 millimeters of mercury in 7 days.
Wow. So I saw one of the experiments you did. You found that nitric oxide was a hormone, right? So,
That's
but
right.
previously we spoke, and it was just earlier you said, "Oh, it's gone in a few seconds." So,
Yep.
how can it also work as a hormone where it has to be like endocrine?
Yep. Now it was really a seminal discovery in a paper we published in 2007. And so in that experiment, again, we didn't design the experiment to prove that. It was based on observations from that data. So we created a mouse that overexpressed nitric oxide, the enzyme that makes nitric oxide, only in the heart. It was called a cardiac specific overexpression or transfection of the enzyme. And so in those studies, in collaboration with David Leffer's group, we discovered that those mice were resistant to injury from heart attack. And so then we started looking at other organ systems, and we looked at the liver, for example, in these mice, and found that the liver was completely optimized in nitric oxide production from the nitric oxide that was produced in the heart. And so this created a little bit of a quandary because we knew that nitric oxide that was produced in the heart was gone in less than a second. So how was it transported to the liver? And then the major question was, well, does this mean anything? Does that change in liver biochemistry confer any protection? So in that study, we just shut off the blood supply to the liver in these mice for 5 hours, and then we reperfused for 1 hour, then we reperfused for 5 hours, and found that the liver was protected from injury, from what we call ischemia reperfusion injury. And it was due to the nitric oxide that was produced in the heart. So that was the first demonstration that nitric oxide is a hormone. And what is a hormone? One, it's a molecule that's produced in one site and has systemic effects that controls a specific structure and function of that organ. And so nitric oxide checked all those boxes. So then that for me was like, okay, if nitric oxide is a hormone, then that changes the way we developed therapeutics or product technology. Because the best example is hormone replacement therapy, right? Testosterone replacement in men, estrogen replacement in women. And so as a man, if you're low in testosterone, we give you testosterone, right? And we don't have to give it to you in your testes. We can give it to you intramuscular. We can give it to it transdermally. We can give it to it as a sublingual troche because it goes systemic. But we don't give you precursors or substrates and hope your body can make testosterone. We have to give you that molecule. So that was the kind of the eureka moment for me. Well, if your body's deficient nitric oxide and nitric oxide is a hormone, I just have to deliver nitric oxide directly to you. And I can do it in the form of a troche. I can do it in the form of an orally disintegrating tablet. And I produce nitric oxide in the mouth. I can do it on the surface of the skin. And we know that it goes systemic because nitric oxide, again, is gone in less than a second. But because of our early work we published in 2001, we knew that nitric oxide can bind to the cysteine thiol of glutathione. It can be oxidized to nitrite. And these are molecules that have a half-life of tens of minutes and hours. And that's the bioactive endocrine function, transport function of nitric oxide that's produced anywhere in the body. So nitric oxide is a hormone.
So it gets connected to the glutathione, and then that gets distributed through the blood, and then it breaks apart wherever it gets to.
That's right. It can stabilize the vasoactive properties of nitric oxide. So that the nitric oxide that, for example, I produce in the mouth through my orally disintegrating tablet binds to glutathione, it's oxidized to nitrite, and that's transported throughout the systemic circulation and can release that nitric oxide upon need, right? It's a reduction, oxidation, potential mediated release of nitric oxide.
Right. So nitric oxide goes down with age. And I saw you have a graph in the book, is that by the time it gets to 60, it seems to be about slightly less than 20%
That's
of
right.
the original, which is quite a frightening thought since I'm 60. Do we know why? Which part of the mechanism is not working?
Absolutely. So you refer to this graph that I took 4 independent studies that looked at vascular function at different decades, from the teens all the way up to the 70s and 80s. And so what this tells us is, and really these studies are only looking at the function of the enzyme. It's not even taking into consideration this enterosalivary circuit and nitric oxide production through the diet. It's only looking at the function of the enzyme. And so what we see is this age-related decline in nitric oxide production and increase in what we call endothelial dysfunction. So we certainly understand what leads to NOS uncoupling and what leads to nitric oxide deficiency enzymatically produced in the endothelium. And the rate-limiting step in that is oxidation of tetrahydrobiopterin, or BH4. So anything that leads to an increase in oxidative stress or chronic inflammation is going to uncouple this nitric oxide synthase enzyme and lead to endothelial dysfunction. So even though that's kind of in the general population of what we see in the majority of the population, today we know that that doesn't have to be the case. We can prevent this age-related decline in nitric oxide production by maintaining the function of the NOS enzyme based on either giving nitric oxide at the very simplest or changing our diet and lifestyle, eliminating sugar and carbohydrates in our diet, throwing in more green leafy vegetables, getting moderate physical exercise, eliminating the use of antacids, the proton pump inhibitors. And now that releases the brakes, prevents NOS uncoupling, and can maintain normal nitric oxide production the older you get. So, we know I'm kind of the best example because I'm the all important N equal one experiment. Chronologically, I'm 51, but biologically, I'm 36. And I'm still trying to work backwards because of trying to maintain normal enzymatic production of nitric oxide.
Right. So for your diet, you low sugar, right? So keto, I mean, all the way to keto or just low carb?
It's mainly low carb. So what I found that works for me is that I do an 18-hour fast every day. Every day. I eat my last meal at 6 p.m. and don't eat again until lunch the next day. And so my breakfast when I break my fast is actually at noon the next day. And I eat mainly high protein. I eat a lot of red meat, eat a lot of meat, a little bit of vegetable. But if I eat carbs, it's a very low glycemic carb. And I typically avoid sugar, supplements with sugar. I don't drink soft drinks or sugar-laden foods. But again, that works for me. And I'm pretty active, right? I work out every day. So if I do eat sugar or have, carbs or something, then I burn it. If I'm working out on the field or going to the gym or something, then carbs can be used as fuel, right? So my diet is mainly, I wouldn't call it ketogenic. It's probably the caveman diet, carnivore, but not straight carnivore. Again, I do eat some carbs and vegetables, but what works for me, I think, is the 18-hour fast. And usually once a week, I'll do a 24-hour fast. Maybe once a month, I'll do a 48 or 72-hour fast.
Can we tell what our nitric oxide levels are? I mean, is there a test or any biomarker we can look for?
The answer is yes. I mean, there are biomarkers that not really that correlate with the loss of nitric oxide production. Those are so what we find in patients who are nitric oxide deficient, they're inflamed, so their C-reactive protein goes up. Their triglycerides are high, greater than 150. Typically, their ferritin levels will be high. So these three biomarkers can cause nitric oxide deficiency, and then nitric oxide deficiency can lead to higher levels of these. So it's this vicious feed forward cycle. And so those are markers that correlate with nitric oxide deficiency. There's, a saliva test that I developed more than 15 years ago that I don't use anymore because there's too many false positives. And again, it's not measuring nitric oxide, it's measuring salivary nitrite, which can be dependent upon many things. Diet, bacteria, oral infections, which we find are false positives, and it's dependent upon stomach acid production. So I really don't use those test strips anymore. So what we rely on are symptoms. And really we don't even, we see symptomology of nitric oxide deficiency along with those lab biomarkers. But, for me, I said there's only two people in the world who need nitric oxide. There's the people who are sick and want to get well, and then there are people who are well and don't want to get sick. So if you fall in one of those two categories, then you absolutely have to have nitric oxide. So there's really no need to measure. I mean, sure, you can titrate in to normalize blood pressure to reverse metabolic disease or look at other clinically relevant endpoints or biomarkers. But I think if you fall within one of those two, you need nitric oxide.
So if we wanted to supplement with nitric oxide, so we talked about the lozenge,
Yeah.
and we'll go back there in a second. But can we take nitrates or nitrites? I mean, would taking nitrites like skip one step, so be kind of better than nitrates?
Yeah, but you have to be careful because that chemistry can be pretty complex. And what we have to do is we want to specifically direct the one electron reduction of nitrite to nitric oxide. We don't want to have a lot of this secondary nitrosative chemistry that can lead to nitrization, nitration of protein. So if you don't understand the biochemistry and really the physical chemistry of what we're doing, then taking that can be very naive. And two, you can overdose on it. And it could lead to an unsafe drop in blood pressure, or more importantly, it could lead to a condition called methemoglobinemia, where that nitrite could oxidize the heme iron of hemoglobin and completely shut down the oxygen carrying capacity of the red blood cell. And in that case, you become acidotic, you become cyanotic, you develop blue around the lips, and it's deadly. People die from that. And so this is not something to be experimented with by the naive layperson. There's a lot of chemistry involved in that. And so, I've spent more than 30 years understanding that chemistry. So that's what we do. We provide nitrite as a substrate that then we provide all the sufficient electrons and prevent the nitrosative chemistry and dictate and control the metabolic fate of nitrite in our product technologies.
And so is this in the lozenge or
It
do you
is in the
have
lozenge.
it is in the lozenge? So let's talk
It's in
about
the lozenge. We make a fermented beet powder where we pre-convert the nitrate to nitrite through a fermentation process by adding the proper bacteria. Because I think you make a perfect point. If you want to use nitrate, there's companies out there selling you nitrate capsules. But again, they either don't understand the inherent limitations in the inert nature of that molecule, because there's so many things that got to be right in the human body. You got to have the right oral bacteria. You got to have stomach acid production. You got to have sufficient enterosalivary circuits intact. And so what we find is, yeah, you may get a benefit from that, but I think it's probably 10 to 12% of the general population. Because the reason people are nitric oxide deficient is typically because they have an oral dysbiosis, they have endothelial dysfunction, they have insufficient stomach acid production. So these products cannot, will not, and do not work in the people who need it the most.
so I have so the let's talk about the lozenge. So the lozenge creates nitric oxide in the mouth,
That's exactly right.
and
So
then that
this
yeah.
is, the challenge was, how do we create a safe and effective delivery of nitric oxide in an outpatient setting? Because again, clinically, nitric oxide gas has been used since the late 80s, early 90s in the intensive care unit for premature babies with pulmonary hypertension, because it's a vasodilator, it's a bronchodilator, and it's very important in pulmonary medicine and critical care medicine because it can dilate the blood vessels of the pulmonary arteries, overcome pulmonary hypertension. It can dilate the bronchiole, the smooth muscle of the bronchioles. And so now you can fully oxygenate, normalize pulmonary pressures, and match ventilation to perfusion. It's a lifesaver in pulmonary and critical medicine. But how do we do this in an outpatient setting? And so this is what I call our orally disintegrating tablet. So it's just this little wafer. You put it in your mouth and you just move it around, let it sit there. But as this matrix is falling apart, it's producing nitric oxide gas. So I'm undergoing hormone replacement therapy right now as we speak. And this lozenge is producing the same amount of nitric oxide that they deliver in the neonatal intensive care unit for premature babies with hypertension. I'm just delivering it in the mouth where they were delivering it as a gas through a nasal cannula. So, and we've demonstrated this. If I were to take an ultrasound and put it on my carotid artery, I know my carotid artery is dilating right now. I know that if my blood pressure was elevated, it would normalize my blood pressure. I know that within, several hours, the number of stem cells in my own circulation are going to increase. We've measured this, we've demonstrated this, we've published this. I know that within 20 minutes of taking this lozenge, my blood vessels have become 20% more compliant. They're going to be 20% more functional in their ability to naturally produce nitric oxide. I know that as this lozenge is dissolving, it's killing the pathogenic oral bacteria and it's increasing the number of the non-pathogenic commensal bacteria. So this simple lozenge completely addresses all aspects of nitric oxide deficiency. Number one, if your body can't make it, we do it for you. But we fix the reason your body's deficient. We recouple the nitric oxide synthase enzyme. We're completely restoring the oral microbiome. So now we're optimizing the body's ability to produce nitric oxide on its own. And that's never been done before. It's the only solid dose form of nitric oxide gas that I cracked the code on more than 15, 16 years ago. Actually, 20 years ago.
So I did try some of those before. They can be a little bit acidic or irritate the mouth a little bit. Have you seen that and have any
We
thoughts on
do
it?
we do hear that periodically, and here's what we found. In people who have a really acidic saliva. So if your pH, and you can develop salivary pH test strips, if your saliva is acidic, then for some reason, and I don't know mechanistically how it's happening, but it can cause sensitivity and irritation. And the analogy is it's like when you eat a hot pizza and it scorches the tongue and the roof of the mouth. That's what people refer this to. So for that, number one, it's almost diagnostic that something's wrong with your oral microbiome and your saliva is too acidic. So very important. I think it's important to understand what that is and then to correct it. But to mitigate the sensitivity of the lozenge, what we find is that if people take, a little teaspoon of baking soda, which is sodium bicarbonate, put in a little bit of water, and then swish that for 30 or 60 seconds, that acts as a buffer and it increases the pH of the saliva. Now, when you put the lozenge in your mouth, it doesn't cause any irritation or sensitivity. So that's a short-term acute fix. But I think more importantly, you have to address what's going on. Are you eating too much sugar? Are you a mouth breather that you're changing the whole ecology of the microbiome and lowering the pH of the mouth and the saliva? And if that's the case, then, tape your mouth at night when you sleep, and you're going to completely change the pH of the saliva. You're going to completely change the microbiome and lead it to a more healthy microbiome, and you won't have a sensitivity to the lozenge.
Cool. I will give that a try. So nitric oxide goes down with age, although that may depend on
Although that,
our
yeah, that
lifestyle.
doesn't necessarily have to be the way. In the general population, yes, that is what
but,
we see.
but generally, we see that.
Yeah.
So, how does nitric oxide, lower nitric oxide, affect some of the chronic diseases of aging? I mean, particularly, I would think about heart disease and blood pressure. We can definitely see, but
For sure.
um, yeah, how does it affect like heart disease or insulin resistance?
So, what broadly speaking, let's look at all age-related chronic disease because I like to start from like a 50,000 view and then delve down into molecular medicine. So, if you look at any age-related chronic disease, whether it's heart disease, Alzheimer's, pulmonary disease, liver disease, kidney disease, there's always four things. There's decreased blood flow to the affected organ. There's inflammation. There's heightened levels of oxidative stress. And then there appears to be some type of immune dysfunction in that organ. And so nitric oxide is what controls all four of those. So nitric oxide dilates the blood vessels, so it overcomes the perfusion problem. It reduces inflammation. In fact, one of my patents is on a method of reducing inflammation with nitric oxide. It inhibits cellular oxidative stress and superoxide production. And it changes the M2 inflammatory macrophages into the anti-atherogenic, anti-inflammatory M1 macrophages. So mechanistically, it addresses the root cause of all the hallmarks of chronic disease. And we know that it's the functional loss of nitric oxide production that precedes these diseases, whether it's heart disease, Alzheimer's, or metabolic disease, by many years. And so that's how mechanistically how it's working. So let's take heart disease, for example. So when you lose the ability to produce nitric oxide, you start to get an upregulation of adhesion molecules in the lining of the blood vessel. So now the blood vessels become like Velcro. Immune cells stick, platelets start to stick. You lose the barrier function of the endothelial cells, so you get lipid translocation or extravasation. And then in that smooth muscle, the smooth muscles start to hypertrophy, called smooth muscle hyperplasia. You start to get foam cells, you get plaque that builds up, and then something ruptures that plaque. The plaque becomes vulnerable and soft. It ruptures, and you have a heart attack. And in many patients, that's a sudden cardiac death. So, how does nitric oxide work? Well, if you can maintain adequate production, you downregulate the adhesion molecules. The blood vessels become soft and compliant with each beat of the heart, so you don't have the shear stress and the damage to the glycocalyx. and you don't get plaque deposition. So maintaining adequate nitric oxide production completely prevents cardiovascular disease. And then in metabolic disease and insulin signaling, we were the first group to publish on this, I believe in 2011, that nitric oxide is required for insulin to do its job. So when insulin is secreted by the pancreas, by the beta cells of the endocrine pancreas, it binds to insulin receptors, and then that extracellular binding transduces an intracellular signal that tells that cell, I need nitric oxide. When nitric oxide is produced, it binds to cysteine residues on GLUT4, induces a translocation from the cytosol to the membrane. Now that GLUT4 can bring glucose into the cell and clear it from the circulation. But if your cells can't make nitric oxide, insulin's still secreted, insulin still binds, but the signal to insulin, you become resistant to the signal because if you can't make nitric oxide, GLUT4 doesn't get the signal to go to the membrane, translocate, and bring glucose into the cell. So insulin resistance in diabetes is a symptom of nitric oxide deficiency. And you can never overcome diabetes and insulin resistance without first correcting nitric oxide production. And we know that diabetes, type 2 diabetes specifically, is treatable, it's preventable, it's curable, and it's reversible. And you do this through diet and lifestyle modifications. So with 9 out of 10 Americans being metabolically unfit, this is completely unacceptable because we know mechanistically what causes insulin resistance, what causes lack of nitric oxide deficiency, and we can fix it. And we see this all the time. If you change your diet to a more ketogenic, low carb, no sugar diet, you get moderate physical activity, and you do intermittent fasting, type 2 diabetics are completely cured. And we can explain it mechanistically. So there's no excuse anymore. I mean, this really aggravates me because the science is there. It's just the implementation of the science into clinical practice and people being accountable and disciplined enough to do it.
Mm. So I was thinking about Alzheimer's. So Alzheimer's is partly blood flow and also partly insulin. So maybe nitric oxide would help with both of those.
Now, absolutely. I'm absolutely convinced that nitric oxide therapies will completely eradicate Alzheimer's. And we're developing drugs specifically, nitric oxide drugs specifically for Alzheimer's. Because Alzheimer's is number one, it's a metabolic disease. And many people refer to it as diabetes type 3 because you see insulin resistance in the brain. The brain likes sugar as a primary energy source. And so if you can't get glucose into the cell, those cells become dysfunctional. When cells become dysfunctional, you get protein misfolding, you get amyloid plaque, you get tau tangles. But even before that, before Alzheimer's, which is characterized by amyloid plaque and tau tangles, we call the preceding condition vascular dementia. So it's vascular dementia because there's a vascular component to it. And when you look at cerebral blood flow or perfusion of the brain through SPECT scans or functional MRIs, you see in every single patient, there's decreased blood flow to the brain. There's focal ischemia. There are parts of the brain that are getting no blood flow. So again, if you're not perfusing parts of the brain, you're not delivering oxygen, you're not getting glucose into the cell, and those cells become dysfunctional, proteins misfold, and that's what we call Alzheimer's. So what does nitric oxide do? It dilates the blood vessels. It perfuses the brain. It improves oxygenation of the brain. It improves glucose uptake. It potentiates insulin signaling. It prevents protein misfolding. That's Alzheimer's. And we know the people who have increased risk for Alzheimer's are the people with ApoA-B. There's certain genetic predispositions. There's lifestyle. People who have a hypertension, diabetes, have a higher incidence of Alzheimer's. Why is that? It's because they're not making nitric oxide, the cause of their hypertension, the cause of their diabetes, the rapid onset and acceleration of Alzheimer's. So I'm absolutely convinced that we will not only slow the progression of Alzheimer's, but we're going to completely reverse it and regress it. Because mechanistically, we understand at the cellular, subcellular, and molecular level how nitric oxide is affecting cell metabolism and blood flow and perfusion and everything we know about misfolding of proteins in Alzheimer's.
Okay, that will be interesting. So
For sure. Stay tuned. We're working hard.
I will definitely be looking out for that. Yes. So nitric oxide also works topically if you put it on skin. So how is it working in that case?
Yeah. This was the impetus for that was really a personal story with my dad, who's a paraplegic. He said that is 70, what is that, 77 years old. But in 1984, when he was 36 years old, he had a car accident, left him paralyzed from the mid back down. And so even as a child in my early adulthood, we were dealing with chronic non-healing wounds, decubitus ulcers, diabetic ulcers. And so he had a 4-year-old non-healing wound that no wound care doc or clinic could heal, despite 40 hyperbaric treatments and all the innovative wound vacs and all the therapies available, the wound wouldn't heal. So in 2014, I started treating this 4-year-old non-healing wound with nitric oxide. I created a topical nitric oxide, a nitric oxide releasing gauze. And within 6 months, we healed this 4-year-old non-healing wound and was remarkable. We saved his life. So then all these wound care docs were like, how did you do this? We've never seen this before. So then I felt I had an obligation to bring the a topical nitric oxide to market. So we sell this today in the form of a skincare or topical serum, but we're obviously developing this as a drug therapy for wound care. But again, we produce nitric oxide. So I had to develop a dual chamber technology that when you combine these two components, they produce nitric oxide gas. So the way this dual serum works is you take one pump from each side, you mix it together, and then you apply it to the skin. And when you improve blood flow to the skin, just like when you improve blood flow to the sex organs and improve blood flow to the heart, that organ performs better. So the skin performs better. What does that mean? Fine lines and wrinkles improve. We improve the number of stem cells. So we improve cellular turnover. We slough off old skin cells and you put in new skin cells. We see an improvement in collagen deposition. So hydration improves, the fullness, the tone, texture, and clarity of the skin improves. So, we brought this product to market in skincare and beauty 6 years ago, and it's been a game changer. And it's the basis now for these non-surgical facelifts. You don't have to have surgery anymore to tighten skin. We just apply nitric oxide and we see nitric oxide do its job and the body respond to it.
What do you see for the future for nitric oxide? What are you working on now?
Well, my goal, and really my goal for the past 20 years, was to understand mechanistically what leads to a loss of nitric oxide production and then develop safe and effective product technology to overcome all aspects of nitric oxide deficiency. So, we've been very successful in the dietary supplement nutritional space. We've been successful in the skincare and beauty space, but the future relies on safe and effective drug therapy and us demonstrating that we can go through the rigor of the FDA and not only prove safety, but prove efficacy of these products in many different indications. So the top three things we're working on is we're developing a drug for ischemic heart disease. We're developing a drug, as we talked about, Alzheimer's, and we're developing a topical drug therapy for diabetic ulcers and non-healing wounds. And as we start to get these drugs through the FDA, do the clinical trials, get them approved and on the market, I think it's going to change the world. We know that, there's a 250,000 people in the world that are living with ischemic heart disease. The cornerstone therapy is organic nitrates, long-term outcome data. People that are on these drugs don't get better, they get worse. They develop tolerance to them. 65,000 Americans die in nursing home every year from infected non-healing wounds that, they develop sepsis and die from it. And to me, that's unacceptable. And then Alzheimer's, the rates of Alzheimer's are quadrupling, determined or predicted to quadruple in the next 5 or 6 years. And there's no effective therapy, despite billions of dollars spent on monoclonal antibodies and drugs targeted toward the amyloid plaque and the tau tangles. They're not effective. And in fact, they're not even safe. And, if that had consulted with me years ago, I could have saved these companies billions of dollars because those drugs can never work because the tau tangles and the amyloid plaque are not causative of Alzheimer's. They're a consequence of disease. You can't target the consequence of disease. You have to target the root cause. And lack of nitric oxide is the root cause of Alzheimer's and any metabolic disease. So I see the future in a world where nitric oxide based therapies will change the landscape of medicine, will lead to the better management of today poorly managed age-related chronic disease, and it'll be the basis for the treatment of, because there's truly no indication where nitric oxide given at the right dose at the right time in the right patient wouldn't be beneficial. We understand the safety profile of it, so safety is not an issue. We just have to determine the right dosing for individual patients with individual indications or diseases and develop a rational therapy for those indications. And so that's where I see it. We're on a mission. We're leading the charge. We've had a lot of opposition and a lot of ridicule over the years, but we're at a point now where we won't be stopped and we can't be stopped. And I'm not building this company to sell it. I'm building this company to bring drugs to market that are safe and effective. And in fact, to bring nitric oxide product technology into every major market segment around the world. We just launched a toothpaste. We're entering oral care because we know how important oral hygiene is. So I developed a fluoride-free, nitric oxide-friendly toothpaste that's remarkable. We're seeing people's blood pressure come down just by changing their toothpaste 2 hours. And to the one of the questions you posed early on, we're developing a nitric oxide-friendly mouthwash because 2 out of 3 Americans use mouthwash, and many people want to use a mouthwash because they want fresh breath. So, we have an obligation to give them a safe and healthy alternative to where we're targeting the microbiome. I don't want to kill the microbiome. I want to support the microbiome. I want to optimize salivary pH and create an environment where the non-pathogenic commensal bacteria can grow, can flourish, and do their job. We as humans just got to get out of the way and let the human body do its job.
Yes. So the Alzheimer one, would that be like a prevention thing, or would it be after when you have MCI, you start taking it, or you know, I mean, it's future, but how would you see that?
Here's what I think. I mean, we have to take this one step at a time because to do drug studies, the success or failure of any drug historically is dependent upon the clinical trial design and the patient population you enroll. So what we're trying to specifically do in our Alzheimer's drug study is we want to enroll patients that are far enough along, but not too far, right? So we want to be able to show in our clinical trial that we can slow progression or prevent the progression. But we also want to show in this particular patient population that if we can see regression, so they want to be far enough along to where we can objectively measure regression, but not so far along that we can't demonstrate any slowing of progression. So that's the goal. But here's what I think. Actually, I believe this. I'm a little bit more convinced than just thinking. I believe this. That once we get these drugs approved and they're demonstrated safe and they're demonstrating effective in patients with diagnosable dementia or Alzheimer's, then I think most physicians, using their best medical judgment and the preponderance of evidence that's out there, will use these drugs prophylactically in patients with what's called mild cognitive impairment early on before dementia and Alzheimer's as an early treatment. And then I think, we'll have to get these drugs approved at different time points because I don't have the bandwidth to do all this at once. But I think, as most physicians do, if a drug is approved for the FDA for specific indications, then many physicians will start to use these off-label, right? So if we get a drug approved, for instance, for ischemic heart disease, then any physicians with any objective data using their best medical judgment would say, oh, I could use this drug for my diabetes patients, my patients with congestive heart failure, my patients with pulmonary hypertension, because we know what nitric oxide is, we know what it does, and this drug produces nitric oxide.
Right. That sounds very promising. So
I'm
excellent.
excited. That gets me up every day with a smile on my face and a mission to move forward.
Yes, that's brilliant. Okay, so if people want to follow your work and find out more information about nitric oxide, where can they go?
Well, I'll do a shameless plug for my latest book, The Secret of
Yeah,
Nitric
sorry.
Oxide,
Yeah.
Bring the Science to Life. This book chronicles really everything we talked about. Richard, it tells the story of nitric oxide, what it is, what it does, what led to a Nobel Prize, and then chronicles my kind of personal journey of discovery. So that's number one. It's a must read. It's number one on Amazon. It's making its way up New York Times best-selling list. And then number two, subscribe to my YouTube channel. We have a very active audience there. We put content on there. It's information, education. That's Dr. Nathan S. Bryan, Nitric Oxide on YouTube. I'm on social media, Instagram, Dr. Nathan S. Bryan, LinkedIn, on Twitter or now X at Dr. Nitric. And I'm searchable by most search engines. So you can find me. And then for those interested in the published scientific literature, you can go to PubMed and just put in my name, and I've published over 100 peer-reviewed papers in the scientific literature. So, but those are technical writings and publications.
Okay, I will link to those in the description. So,
Yeah, and then those interested in product technology, obviously, if we make safe and effective products, those can be found at n101.com. That's the letter N, number one, letter O, number one.com.
okay, we'll include that too. Okay, Dr. Bryan, thank you so much for joining us again today. It has been great talking to you.
Thank you, Richard. Always good to see you.